right-based existential psychiatry, and deep therapy, dynamic eclectic existential psychopharmacotherapy, which is a concept presentation in psychiatry. I have no disclosures. So I'm going to talk about right-based psychiatry, existential psychiatry, and then the new concept that is going to be introduced via this presentation, right-based existential psychiatry and deep therapy. So some basics, I go very quickly through that. Human rights, rights and freedom that all individuals are entitled, regardless of their nationality, ethnicity, gender, any label. You remove the labels and you say that everybody is entitled to these rights. It's the notion that has been among humanity but became more prominent after World War II because of the human rights abuses that happened during the war. Um, Historically, human rights, as I said, has been from Code of Hammurabi, Cyrus Cylinder from Persian Empire, or Magna Carta from the UK. But the most important documents of human rights go back to the United States Declaration of Independence and Constitution. And then after World War II, the UN Universal Declaration of Human Rights, 1948. So you can see that the human rights in this United Nations document, it includes equality, no discrimination, liberty, freedom of speech, privacy, freedom of choice, freedom of expressing opinion and religion. There are some areas that are not included and are debatable. These areas are like work and employment, affordable food, shelter, education, affordable health, and the very controversial area of right to a dignified death. But we can talk about that maybe later. So based on the United Nations Charter of Human Rights, in around 2006, 2008, United Nations introduced another convention, which is CRPD. And that's something that I would like all of us as physicians and healthcare professionals know. That's Convention on the Rights of Persons with Disabilities. Majority of countries in the world, they have approved the convention, but almost no country, very few countries, they have applied it in the law. And interestingly, United States has not even approved the CRPD. But CRPD is to promote, protect, and ensure the rights of people with any sort of mental or physical disability. So the idea of CRPD is that the United Nations Charter of Human Rights applies not to all human beings, but also to people with disabilities. It has 50 articles. And the most important relevant thing for psychiatry is that CRPD requests or kind of advises reform of mental health acts to remove any form of coercion and substitute decision making in mental health services. So the key articles relevant to mental health care is accessibility, equal recognition, liberty, freedom from inhumane treatment, protecting the integrity of person, living independently, included in the society, and right to employment. One of the biggest concepts of human rights, some of the biggest concepts of human rights in mental health based on Charter of Human Rights and CRPD is respect for autonomy, and I did a little bit of work in human rights when I was in WHO and with the UN. I know the biggest focus is on autonomy, choice, and the substitute decision making. That CRPD recommends instead of substitute decision making, we use supported decision making. So the decision is at the end for the person, not for the substitute to make, but the substitute just helps. The other concepts like non-discrimination, I use the word limiting coercive measures because as a clinician, I know the terminology of abolition of coercive measures that human rights advocates they use. It's almost impossible. Dignity and respect, participation, person-centered care, and supported decision-making. Now, After working a little bit in human rights during my residency, after finishing my residency, I had the pleasure of working with Dr. Viviet, Jerry Viviet, as my mentor to learn about existentialism. I actually had an interview with him a couple of days ago. I'm going to share the video later of that interview. But I realized there are a lot of overlap between right-based psychiatry, human rights-based psychiatry, and existentialism. Now, briefly about origin of existentialism, it goes back to Schopenhauer when he talks about will to survival. He says that everything that we do as human beings goes back to our survival instinct. So we do it to survive. And then Soren Kierkegaard, the Danish philosopher, was considered as father of existentialism because he's the first person who talked about choice, that we choose to believe in something. He said that I choose to believe in God despite the fact that I don't have any evidence for that. So it was like the idea of leap of faith. And he said that a lot of anxiety and despair of human condition comes from the freedom that we have to choose in what we believe or what we do. Then Friedrich Nietzsche, who is an interesting philosopher because there's a nice article, anybody is interested, I can send. He is probably the father of psychoanalysis and psychodynamic, psychoanalytic psychiatry, but Freud kind of got the credit for that because a lot of ideas of the unconscious, of the motives from previous experiences, eternal recurrence, like what Freud called it, repetition compulsion. They come from Friedrich Nietzsche. He talks about will to power, and he says that it's not only because of survival what we do, it's because we want to gain power and we want to become kind of an Übermensch, which he means a human being who knows right and wrong deep inside and doesn't need religion or law. And he brings the idea of amor fati. I will talk about amor fati when we are talking about acceptance later. Then the 20th century existentialism, a lot of these, philosophers, the existence precedes essence. Sartre says that first we exist, then we will have a meaning in life. And authenticity that Heidegger brought to psychiatry, to philosophy, and Albert Camus talked about absurdity of life. He said that there's no meaning in life, but still it's enjoyable. You don't need to have a meaning to enjoy life, to have a purpose. And one of the most relevant ones to us, to psychiatry, is Martin Buber, who brought up the idea of dialogical existence, which applies a lot to the therapeutic relationship. Martin Buber says that we have two types of relationship: I, you, and I, thou. I, or I, you. It means that I know the answer, you come to me to get help. And that's the most common therapeutic relationship between physicians and patients, that I'm the expert, you come to help. But I-thou relationship is a higher level of relationship, that we are both journey travelers. I don't know the answers. I'm going to explore. We are going to explore together. And that's the existential level of therapeutic relationship. Now, existential psychotherapy. So existentialism by Nietzsche and people that we talked about, they were more in realm of philosophy and literature. But Binswanger was the first person who talked about analysis of being, an existential analysis. Rollo May later wrote a book named Existence, and he kind of used the analogies and methods of Sigmund Freud in psychoanalysis in analyzing somebody's thought in regard to his existence. Viktor Frankl, we all know, who was a psychiatrist in Auschwitz himself, and he found out that the reason some people survive and some people don't survive is the meaning that they give to their suffering. He has a very famous saying that suffering ceases to be suffering when there's a meaning in it. And he created logotherapy, which was one of the first methods of existential therapies that can be applied in psychiatry. It's like finding meaning in suffering and situations. And then our contemporary psychiatrist, who is still alive in 94, Dr. Irving Yalom, used all the existential philosophy and existential analysis to create existential psychotherapy, which is based on 4 givens of existence, working on death and mortality, freedom and choice, isolation and connectedness, and meaninglessness. And he says that majority of human suffering, depression, anxiety, even mania or psychosis, they come from conflicts in either of these 4 domains. So the concepts in existential psychotherapy that Irving Yalom talks about is existential angst. He mentions the idea of Goverfanheit, the thrownness, that we are thrown on earth, and as soon as we understand that we are thrown without any meaning and we are here all alone, it makes us feel anxious. We are isolated, we are born alone, we die alone, and we have a sense of feeling of solitude, searching for solitude, but at the same time, we are social beings. So there's a conflict in us in terms of socialization and solitude. And then the death mortality, which is the ultimate human fear. We don't want to talk about it, but that's fearful. That's the most uncertain reality in human life, and that we all share, regardless of any other label that you want to talk about. And then the idea of revolt and rebellion, that at some point when we understand that there is no meaning, we are desperate, we will die, we want to rebel, we want to do something to change this destiny of death and uncertainty and the absurdity of life. So key concepts: capacity for self-awareness. Majority of existentialists, they believe that all people, they have the capacity to know themselves and to get improved. Carl Rogers talks about unconditional positive regard, says that regardless of whatever the symptom the patient has, whatever violent or aggressive behavior they have, as a mental health professional, you should still have an unconditional positive regard, because you don't know what they are going through in life. And then freedom and responsibility and authenticity, which is a very big important thing in existential psychotherapy, to help people to become one's true self, to become who they are, to remove the persona and mask of societal pressure, what Carl Jung talks about. So working in human rights and then learning about existential psychiatry, I realized that there's a lot of common grounds between these two. And for me, personally and professionally, the combination of both can explain mental health and psychiatry. I'm not a very biomedical person in terms of psychiatry. I did my fellowship at Hopkins, and there's super biomedical neuroscientific area, and I thought that it doesn't resonate with me, this model of looking at psychiatry. So I thought that we can combine it and create right-based existential psychiatry, which is based on human rights approaches and the common grounds with existential philosophy. It's an approach to mental health care that integrates the principles from human rights and the therapy techniques from existential philosophy and existential psychotherapy. So it creates a space of respect and upholding rights of the patients. The emphasis in right-based existential psychiatry is on dignity, autonomy, authenticity of the patient's capacity to decide, and rights of the individual. it helps the patients to go with deeper existential questions and meaning of life and meaning of their suffering, and to find a way to go above and beyond their suffering, to use the suffering as a way of getting post-traumatic growth rather than post-traumatic stress. And the main focus is to address the existential concerns, like, as I said, isolation, meaning, death, choice, responsibility. And there's a lot of respect on people's choice in the throughout the therapy process. So it's, who is it useful for? It's useful for majority of people with mild, moderate mental health conditions. Probably it's not very much applicable to acute or emergency settings or severe persistent mental illness settings. However, I believe in every setting you can still have an existential orientation, even when you're working in the emergency with the most psychotic patients or the patients with the least insight. Still, you can have existential orientation, but the most usefulness of this method is people with quite insight, psychological mindedness, mild, moderate symptoms, who feel alienated from the traditional psychiatric model, because traditional psychiatric model are either biomedical, looking at medication and neurotransmitters, or psychoanalytic and cognitive behavioral, to just look at, where does these symptoms come from and how can we change your behavior or thought, rather than looking at you as a human being. So if we accept right-based existential psychiatry as a framework, then we need a therapy model. So, and I thought this therapy model cannot be a rigid frame of therapy. Carl Jung says, when a doctor tells me that I'm using this or that as school for therapy, I doubt about his effectiveness, because the answer to the problem is individual. So it means that you cannot use a school, and I firmly believe you cannot use one school of therapies or psychotherapy or medication management and apply it to all your patients. So I created this dynamic, eclectic existential psychopharmacotherapy, deep therapy. It has multiple modules, and it's an eclectic model, that can be used in psychotherapy and medication management. Why eclecticism? Because eclecticism means that you do not adhere to one frame. You know multiple frames, you know multiple schools, and you integrate these techniques and theories and principles to use the best for the situation of your patient and for the session actually that you are having. Eclecticism lets you to be patient focused, to be flexible and adaptable, to be pragmatic and empirical, rather than adhering to a school of therapy. Adhere to the need of your patients, and it enhances therapeutic relationship with the patients. In eclecticism, the focus is on common elements of psychotherapies, and we know the number one, based on research and evidence, number one predictor of outcome of any psychotherapy model or even medication management with the patients is therapeutic relationship and alliance. So in eclecticism, relationship is the focus of the therapy. And then hope and positive expectancy. I consider hope and positive expectancy one of the reasons that the traditional healers, they still exist. That's one of the biggest difference between traditional healers and physicians. We physicians, we look at evidence and data and we say that there's this percentage of hope or no percentage of hope. But traditional healers, they build hope and reinforce positive expectations in the patients. And we have lost that as physicians because of the statistics and data that we have had. Now, the therapist factor, like flexibility, adaptability, and patience factor are also important. Some other common focuses of Eclecticism in psychotherapy is creating insight, using psychoeducation, being sensitive to the culture, use techniques like behavioral activation, meaning making cognitive changing and clarification of values that works. Now, the deep therapy, dynamic eclectic existential psychopharmacotherapy, a big name, but deep therapy makes it short and quite catchy. It offers a structure to deliver personalized, ethically grounded, right-based, culturally sensitive, and existentially attuned care. It has 7 modules, that the modules are not linear. The therapist should know the modules and apply the techniques within each module based on patient's need. The modules are alphabetical A, B, C, D, E, F, G. We will talk about that later. Each module is evidence-based, comes from a school of psychotherapy or therapy or medical schools that is already tried and has enough evidence behind it. But these elements are unified by a shared commitment to respect patient's narrative, patient's choices, and patient's condition. So this is a pictogram of the 7 modules. Module 1A, acceptance, 2B, behavioral change, then C, cognitive restructuring, D, dynamic analysis, E, existential exploration, F, focus pharmacotherapy, and G, grounding techniques. So acceptance, we all know it comes from mindfulness-based therapy stance rooted in DBT, acceptance and commitment therapy. It's the amor fati of Friedrich Nietzsche that I talked about. It's like understanding and accepting that if you're supposed to come back to this life for thousands or millions of more times, you would like everything happen exactly as happened, regardless of the traumatic nature or the terrible nature. You accept it to happen because you are who you are because of all that happened to you. And in other sense, to accept that you are not what happened to you, but you are what you choose to become, as Carl Jung says. So it's like focus on present moment awareness, psychological flexibility, and then accepting all your inner experiences, any thoughts that you have, any emotions that you have, name your emotions and accept them, behaviors that you have, accept them as is, and accepting the external events, traumas, life situations, anything that it's not in your hand, and try to work with it. Don't suppress them, don't judge them, don't alter them. You accept them, and then we will talk about later, you try to integrate them into your life. So it's not like accepting 100% of who you are and be as terrible as you are, but accepting who you are and trying to work with it and integrate it into your life. So the techniques that are used for acceptance are mindfulness techniques like body scan, open body monitoring or breath awareness, cognitive diffusion, like whenever you have an obsessive thought, intrusive thought, you say that, thank you, mind, just smile at it. And the exposure-based strategies like imaginal exposure or other ways of exposure. Then after accepting your internal and external world, the easiest thing to change are behaviors. So the B goes for behavioral change, and it draws primarily from behavioral therapy, behavioral activation. It looks at the behavior of the patient and gradually replace the unhelpful behaviors without judging them into more helpful and healthier behavior. So the goal is to reduce avoidance behavior, to build routines, and to increase stability, sleep, self-care, physical activity. The difference between behavioral change in deep therapy and behavioral therapy or cognitive behavioral therapy is that in deep behavioral interventions are not prescriptive. are not externally imposed. The therapist does not consider himself or herself as somebody who knows the answers and is prescribing what to do, but the therapist is just exploring collaboratively with the patient to design an existential dimension to the behaviors to be able to understand the nature of behavior and change it to the more helpful one. So we don't have bad behavior, good behavior. We just want to change unhelpful ones to more helpful ones. So the strategies that are used in behavioral change are like exposure therapy, behavioral activation, harm reduction, social skills planning. Now, C, the third module stands for cognitive restructuring. So after changing behavior, now it's looking at thoughts. I don't want to go deep into details because all of you know better than me the cognitive behavior, cognitive aspects of cognitive restructuring, looking at automatic thoughts, core beliefs, and what are, again, unhelpful thoughts without judging them, without labeling them, just trying to understand them, the existential meaning of them, and changing them into more helpful thoughts. And the most important factor, again, is that the therapist is not here to label the unhelpful thought or distortions in thought, but is there to have Socratic questioning, guided discovery, understanding the thoughts. So I'm terrible, nobody loves me is not a distorted thought in deep therapy. It's a meaningful way of looking at life. It has a meaning inside. It has a reason that somebody thinks that I'm nothing. I don't have, I'm not loved or I'm not lovable. So the role of the therapist is not to change the thought, is to explore the thought, to sit with the thought and try to understand where it comes from and how the patient can change. And the second thing in deep is the deep therapist accepts realistic fears and anxieties. So fear of mortality, if somebody is really, in a terminal cancer situation and has major depression, that depression is a realistic depression. Imagine you have built a life and now in your 40s, 50s, you're dying in 3 months. That's normal to be depressed. That's not an inhumane or abnormal or pathological reaction to that life circumstances. So deep therapist is aware of that. So again, we are not changing distorted thoughts into more normal thoughts. We are changing unhelpful thoughts, restructuring unhelpful thoughts to helpful thoughts. And the techniques that are used in cognitive restructuring are exactly the same as cognitive therapy techniques like thought records and analyzing advantages, disadvantages of thoughts. D stands for dynamic analysis. This is the fourth module. It's based on psychodynamic, psychoanalytic. So I don't want to go into details. I know most of you are more psychodynamic, psychoanalytic experts than I know about it. But the main thing is in deep therapy, the focus is not on transference and countertransference. The focus is on relationship with the patient, is on here and now, rather than looking at why you have this relationship with me because you take me as your father or you take me as your mother, but how is the relationship with me now? And how does this relationship with me applies in your life? Is it helpful or unhelpful? And how can you understand that relationship? And mostly the focus is to help the patient to have insight into persistent patterns, to have insight into the unconscious world. I'm a firm believer in psychoanalysis and psychodynamic as a pure science, but I believe that it doesn't help majority of the patient. It doesn't help you to know where does your behavior come from. why you do what you do. Why do you repeat the same pattern all along your life? But yeah, maybe that's the reason that you do, but it doesn't help you if you know it. So as a deep therapist, the deep therapist accepts and understands and analyzes the patient based on psychodynamic, psychoanalytic lens, but doesn't necessarily voice it out during the therapy. He understands and tries to kind of convey the message to the patient in an indirect way. So we acknowledge defense mechanism, attachment styles, but again, not in a way to change them, but in a way to understand them, to sit with another human being and help them to understand themselves, to know there are unconscious conflicts and unresolved griefs, unmet childhood needs that they need to work on and or they need to think about. Then the E module is the most important one and the basis of deep therapy, which is existential exploration. It aligns with the right-based existential psychotherapy framework. It's looking at the fundamental conditions of existence: mortality, freedom, choice, responsibility, authenticity, and search for meaning, and trying to find out the meaning of each area and the conflicts that might be there in each area. There are a lot of techniques in existential exploration, existential psychotherapy. I'm not going to go into details. It takes an hour, but some of the main ones are here and now processing. Existential confrontation, ask the patient about looking at their life, birth, death. What do they want to write on their grave? How do they want their funeral to be held? You know, these things that are we avoid thinking about and talking about. We prefer to talk about our breakups and relationships and relationship with parents or family rather than thinking about our death and mortality reflections. Socratic dialogue, life review, life timeline, value clarification, meaning making exercises, boundary experiences, rippling effect. It's a very nice idea that Irving Yalom talks about, that any behavior, anything that you do, it affects yourself, your family, people around you, and the world. Something like butterfly effect. People want to do something big. I want to change the world. You can change the world by changing yourself. There is a rippling effect. Your change influences everybody around you. Symbolic letter writing, write letter to your death, write letter to your fears, write letter to your dead father. These are all techniques that can be used. Freedom, responsibility, inventory, imaginal dialogues, and a lot of other techniques that I can talk about in detail in another session. So originally I finished at E, and then when I was talking about it with one of my friends who is a psychiatrist, he told me that, so does it mean that A, B, C, D, E, if they don't work, your patient is effed? And then I said that no, the patient is never effed. I'm a psychiatrist. I believe in medication. So then I integrated focused pharmacotherapy. So this is like pragmatic, evidence-informed use of psychotherapeutic medication. So that psychiatrist uses the same therapy techniques during the therapy plus medication management. If the therapy is provided by a psychologist, a medical professional who can prescribe will be added to the picture, who is existentially oriented also. Because the most important thing is to be evidence-based, to be based on all guidelines, but make the decision with your patient. So the final choice, the final say is the patient's decision and patient's choice in focused pharmacotherapy in deep. And then finally is the G, grounding techniques. And that I added actually when I visited Auschwitz, because I thought that people in crisis, terrible situations, my model is not going to be helpful at all. But then I thought, okay, I can add a seventh module and talk about grounding, because Kierkegaard has a sentence, and it says that if you are sentenced to death and two officers are holding you to take you to your gallop, you will still have a choice. And your choice is to choose how to behave in the last 3 minutes, last 5 minutes of your life. So even if you are the worst crisis of your life, you still have a choice in existentialism. And your choice is how to control your inner world and your behavior. So grounding techniques like somatic, sensory, cognitive grounding, and existential techniques like letter to fear or something can help with the grounding. So this is just a concept introduction. I have tried it, in my own practice. So I have a kind of case series, and the concept introduction is now as an article under review in a journal. But the next step is most probably doing the case series, case presentations, and then eventually probably if doing research to compare it head to head with other schools of therapy. Now, thank you for listening, and I'd be happy